Here we go. We're doing a question on open globe injury for US only Step 2 CK. We have a 32-year-old man who's brought to the emergency department due to an eye injury. The patient was driving his Toyota where he got struck in the intersection as a flying entity struck his right eye. Due to this, he has pain, foreign body sensation, feeling. He has excessive tearing, decreased vision in his eye. There's discomfort as he keeps his right eye closed. Which of the following findings is most suggestive of acute globe perforation in this patient? So our answer choices include periorbital ecchymosis, corneal cloudiness, hypopyon, perilimbal injection, and a fixed teardrop pupil. Okay, the answer is going to be fixed teardrop pupil. First of all, this is a open globe injury, and our risk factors are going to be blunt force trauma and penetrating trauma, laceration, and rupture. Clinical features of open globe injury, you got to know these: extrusion of the vitreous, eccentric or teardrop pupil, decreased visual acuity, relative afferent pupillary defect, and a decrease in the pressure of the eye. How we manage this is through multiple ways. Obviously, eye shield, emergency ophthalmology referral, CT scan of the eye, intravenous antibiotics, and tetanus prophylaxis. This patient had a high velocity projectile injury to the eye. However, the object is not identified on the inspection, which signals to us that it's going to be an open globe laceration with an intraocular foreign body. Open globe laceration is typically caused by small high velocity particles sent airborne by power tools, lawn mowers, motor vehicle accidents, and during explosions. Penetration of the globe most commonly occurs at the cornea. We have large open globe laceration may present with globe deformity, again, extrusion of the vitreous or iris, and a visible entry wound. In the absence of an obvious wound, OGL, open globe laceration, may be inferred by peaked or teardrop pupil. The teardrop pupil refers to the iris stretching due to the laceration or foreign object, increase or decrease anterior chamber depth, reduce intraocular pressure. Other potential manifestations include loss of visual acuity, like I've said before, and absent afferent pupillary response. If the open globe laceration is suspected, further assessment should be performed with fluorescein drops as the aqueous drains through the puncture site. Fluorescein may be seen streaming away from the site, or clear fluid may be seen flowing through the fluorescein. Management of OGL, as I stated before, requires shielding of the eye and emergent consultation with ophthalmology for surgical repair. Chronic complications can include infection, endophthalmitis, post-traumatic cataracts, and vision impairment. Okay, for our other answer choices, we have hypopyon, which is layering of the inflammatory cells in the dependent portion of the anterior chamber. Perilimbal injection, which is also known as ciliary flush. This is where you have dilation of the blood vessels at the junction of the sclera and cornea. These findings are seen in a variety of inflammatory and infectious conditions. These inflammatory conditions include anterior uveitis and iritis, and these infectious conditions include endophthalmitis and keratitis. Although open globe laceration can lead to endophthalmitis infection, these findings would not be present. Periorbital ecchymosis, raccoon eyes. This suggests that we're going to have an orbital skull fracture. Orbital fracture with globe rupture typically occurs with blunt trauma. And where we have cloudiness of our cornea, this is going to suggest angle closure glaucoma, which most commonly occurs in older individuals and is associated with headache, nausea, conjunctival redness, and a fixed dilated pupil. Again, to recap, open globe laceration is caused by high velocity small particles that are sent airborne by power tools, explosions, lawnmowers, or motor vehicle accidents. Large open globe laceration may present with globe deformity, extrusion of vitreous or iris, or visible entry wound. Other manifestations include a peaked or teardrop pupil, asymmetric anterior chamber depth, loss of visual acuity, or afferent pupillary response, and reduced intraocular pressure. Thank you for watching. I hope this was helpful.